Okay, well, for those of you who just joined, let me quickly introduce myself again. My name is Alex Mitchell. I'm a marketing communications manager with the Lighthouse Lab Services marketing team, and thank you for joining us for our latest webinar. Today, we'll be discussing how to prepare your lab for the rise in payer audits and takebacks. It's definitely a hot button issue that we've really seen a lot of action around since the end of the COVID public health emergency in May. And we're really glad to have two of our leading experts from our RCM solutions team here with us today. We have Cassie Penn, who's an RCM client manager for us, and Ann Lambrix, who's the VP of our RCM solutions team. It heads up the division's day-to-day operations. Both have extensive and deep experience in lab and pathology billing, including audit compliance and different areas of your front and back end processes that you should shore up in order to avoid the scrutiny of regulators and payers. So we're very excited to hear more about what they have to say for us today. Just quickly want to touch on a few housekeeping items here before we get started. You can reduce your chance of buffering or having any lag during the presentation if you close any bandwidth heavy apps you might have running in the background. The webinar will be recorded. Everyone's going to automatically receive a recording when that's available to the email address that you registered under. If you would like the slides for the event, those are available to download under the handout section, so feel free to do that at your convenience. If you'd like to ask us questions, we're going to have a Q&A session at the end as time allows. Feel free to, as we're going through the event, drop those questions into the Q&A box. We'll be monitoring those and moving them to the published section. And as I said, touching on them at the end. And we're also going to run polls during the webinar. We encourage you to participate in those to help stay engaged, but they're completely voluntary. And if you'd like to skip them, feel free to exit out and continue on with the presentation when you see a poll. We'll have a couple offers for you as well to get in touch with us at the end. So if you'd like to contact us, that information will be available. And just briefly, a bit about Lighthouse for those of you who may be new to our webinar series. We provide a host of comprehensive services for medical laboratories, and that's how we're able to keep these webinars free. But we're one of the nation's leading and most trusted end-to-end full-service medical laboratory consulting and recruiting firms. Whether you are looking to start up a lab or grow your current business, we offer labs a way to accelerate their success. So please, like I said, if there's anything that you hear today, whether it's audit reviews, audit preparedness, or any other aspect of the laboratory business that we could help you with, please get in touch with us at the end. And with that, I'm going to go ahead and turn things over to Ann.
Yay, thanks, Alex. Hi, everyone. I'm really looking forward to this conversation today. And again, I think it's a really relevant topic, especially now with the public health emergency being lifted. Audits are not new. Payer audits are not a new thing. It is not something that is happening just because of the public health emergency. But this discussion today is really to talk about maybe the increase of auditing that we're seeing and steps that you can take to not only potentially avoid, but to prepare yourself for an audit. We feel it's not if, it's when you will be audited by a payer. And especially now when we do see the influx of auditing going on for clinical laboratories. To start off, let's just talk a little bit about why payers audit. Payers expect you to understand the rules, and what that means is they are trusting you when you submit a claim for that claim to be medically necessary, the services were performed by you, that you have documentation to support that the services, again, were medically necessary, performed appropriately, etc. When you submit a claim, documentation does not go with that claim on initial submission. You're providing a CPT, a diagnosis code, information about you, the laboratory, the ordering physician, etc. And so when the payer gets it, goes through a system, they process it and pay it. They're expecting you to understand the rules in order to submit a claim. Payment will be made many times in good faith. indicating that the payer agrees that you've performed this test and it's a payable service, therefore they're going to pay. What is important to note is many payers, especially Medicare, is what we would deem a pay and chase payer. That's the kind of model that is set up. They pay it, and then they'll look at algorithms and information that may show an outlier, and then they will have an audit performed. Studies show that there's inaccurate processing of payments. So again, when you're submitting a claim, it's going through a system. Back when I first started in the industry, this is dating myself, but we didn't have the technology to actually process the claim according to edits and benefits that were loaded into the system. So my first role in this in healthcare was to actually go and process claims that were submitted. I worked for a third-party administrator. We applied the benefits manually. That was a really long time ago. That doesn't happen anymore. There's systems that are created to take the information that you're submitting on a claim and to process that claim and apply the appropriate fee schedule, apply the edits in the policy that are going to bump up against, again, what the CPT and the diagnosis code that you're submitting. Guess what? That doesn't happen accurately all the time. Things get loaded incorrectly or something glitches in the system and claims get processed and paid incorrectly. So that's another reason why a payer audit. It may not be that you've done something incorrectly, but perhaps their system processed and paid you incorrectly. So they're going to go in and most likely try to recoup that overpayment. They're also looking to identify red flags in your claim submission. So when there are outliers to a utilization, for example, if there's a lab that's performing a high number of high complexity tests outside of the norm, that's going to flag a payer to say, let's go in and check and see what's going on. Unbundling, overcoding, overutilization are all three areas where a payer is most likely going to audit to find out what's happening and if you are in fact submitting claims appropriately and getting paid appropriately. So why the uptick? We can blame COVID. I think that there's a lot to be said about, the last 3 years and the chaos that ensued with the public health emergency. There was a pause in auditing. As I mentioned, auditing by a payer is nothing new, but because of the public health emergency and focus being really put on just treating patients and slowing the spread, payers paused their auditing procedures. So guess what? Now they're back at it. And so you're going to see an uptick in auditing. And there were some waivers and flexibilities that were applied due to the public health emergency. And so because of those waivers and flexibilities, it became a little bit easier to submit and get paid from a payer, especially with COVID testing. So what we're seeing now is that because of those waivers and flexibilities and because of the COVID health emergency, many providers got a little sloppy when it came to billing claims and having the appropriate documentation to support their testing. Payers are now going to go back and start looking. And even though there was waivers and flexibilities applied, there were still the billing guidelines that were standard that should have been followed. So they're going to go in and look to see if those were followed. And as I mentioned, looking to see if they can potentially recover some erroneously paid claims. We see that there's an increase in technology. That is nothing new. The more technology, the more ability that the system can identify those outliers to reimbursement, to high complexity or the utilization, the number of tests being billed. They're able to data mine quickly instead of having, a resource that's going through and trying to find if there's something going on. That's what I did back in the day. Is there a potential issue here? The system's going to do it. It's going to spit out. Let's look at the 10 cases for this particular provider. It makes it a little bit more easy to identify those outliers. We see an increase in outsourced third-party billing auditing vendors. You may not get an audit from United Healthcare or from CMS. It may be a third party that these companies have hired to come in and audit your claim submission. And then finally, I put because I think it's important to note. They can come in and audit you. If you have contracts in place, they're typically within a contract, a payer contract between a provider and a payer. There's language about auditing. And if you're out of network, again, they're still going to come in and audit. Why? Because going back to that first slide that I mentioned, they're paying you in good faith. So they're going to come in, and there's no regulation that says they cannot come in and audit you. And I would argue that they should come in. It is to prevent fraud, waste, and abuse. And if you are acting in operating on the up and up, and that's what we're going to talk about in a little bit, how to prepare, you have nothing to fear. There is a lot of auditing going on. I wanted to mention we're getting the prospective audits. We're seeing a lot of these right now. Prospective audit would be in the form of a prepayment review. Payers such as United Healthcare and Anthem will request medical records on every single patient that you submit or claim that you submit. So it holds back any payment. It's a prepayment review to look at your documentation to validate if the services were medically necessary, that your documentation supports. Once you get stuck in that prepayment review, it is a real pain in the neck to try to get out of it. So we want to try to avoid getting into that. And like I said, we'll talk about that a little bit. In clinical audits, this is where clinically they'll come in and again, look to validate the testing being performed, the services are medically necessary. Those are prospective, meaning before they pay the claim. And retrospective is probably what most of you are familiar with, is where a payer, after 2 years of submitting claims, a payer comes in and wants to look at a select number of cases to audit. You're scrambling to pull documentation from months or years ago. That's a retrospective, and we are seeing an uptick on that, especially with COVID testing. And then one of the things that we're noticing is the OIG work plans are mentioning toxic out, so urine drug screening. I believe the COVID add-on U005 is on the OIG work plan. And I noticed for June 2023, Medicare payments for clinical diagnostic lab tests is also listed on the OIG work plan. Cassie, was there any that I missed from the OIG work plans that would be relatable to laboratories?
No, I think you covered them.
Okay. And as I mentioned previously, we are shouting from the mountaintops, be ready. It's not if, it will be when you get audited. So let's prepare. With that, Cassie Penn is one of our client managers, and she works directly with our clients that may be going through an audit. And there are some things that with her expertise, she was a lab manager and really can help identify on the front end, what do we need to do to prepare? And if we get audited, we're ready and we can pass with flying colors. So I'll pass it off to you, Cassie.
Thanks, Anne. Like Anne said, how do you prepare? Because we know audits are coming, so you're probably going to get one. Things to look at: internal evaluation of processes. Looking at your processes and seeing where you might have some issues and getting those fixed prior to the audit coming in. So front end processes, patient demographics, requisitions, charge capture, and then the back end. What kind of denial trends are you seeing? Asking why. Is it recoverable? Can you fix it? Really trying to put those workarounds in there to prevent those denials. And then if you do find areas that need work, fixing them, training your team, and then asking for help if you feel like, you need some additional help with those processes. Because as we look at the whole process from the beginning to the end, it's complicated. There's a lot of data coming in. It's coming from multiple different clinics, especially if you have a reference lab. So there's just a lot of pain points as you're trying to bill compliantly. So if you look, the ultimate thing that you're trying to come across is you're trying to be compliant in your billing. So there are certain things that flow up into your billing compliance. So patient demographics is the first part. That's the information coming in. Do you have a flow of clean data? What is your process for getting that? We know a lot of laboratories struggle with either no data or incorrect data. So putting technology in place to really help bring in correct information so that you can bill the correct payer. Requisitions is another area. You want to ensure that those requisitions that are coming in for most laboratories, especially if you're a reference laboratory, your requisition, you're utilizing that as your order. So you want to make sure that it meets the standards for an actual order. So does it have a physician signature and does it have the diagnosis code? And then charge capture. Are you reviewing your CPT coding? Do you have the correct codes? Are the codes dropping the way you want them to? In our automated world, those codes are just dropping. So you want to check periodically just to make sure that you have them mapped correctly. The other thing really to look at is building rules. Are there rules built in the LIS and the billing system to help with that charge capture and ensure that you're not duplicate billing? Because though duplicate billing is going to be a red flag for those payers. Looking at the front end process, and we're starting to see this quite a bit, and this is an area that probably gets overlooked a little bit, but payers require the services to be authenticated by the ordering provider via signature or intent. So in the grand scheme of things, when your claim is going out, like Ann said, you're going to have your CPT code, you're going to have your diagnosis code, but the payer's not going to see that order. They're not going to see that physician signature. But when it comes into play is if there's a request for medical record or the audit comes in and they want the documents, if your requisition is not complete, you have to show that intent. So that's going to require you going back to your clinics and trying to recover medical records from their system to show that intent. So for laboratories, especially reference laboratories, ensuring that requisition is complete helps in the back end when you're getting those requests. If you get a medical record request and let's say the billing team just pulls the requisition, they don't look at it, ensure that it's complete, that gets sent into the payer, that's a red flag if it's missing, because then they're going to come back and say, the order's not complete. They may request an additional 20. It just really, it really puts the eye on you if you're missing those. The other thing is to utilize the technology when it comes to the orders and the requisitions. Try to get away from the paper requisitions and the actual handwritten physician signature. If you can implement e-orders, that's great. One thing that I do caution for laboratories is to go back and look at your e-order system and ensure that it has a true electronic signature on there, because we have seen that these requisitions that are coming out from e-orders, it's not an acceptable electronic signature. So if you send that in, you're going to have issues because they're going to come back and say that it's not a proper order. The back end, looking at your denials, really understanding what kind of denial trends you're seeing. Denials can be an indication for payers to maybe dig a little bit deeper. So for example, CO50, which is lack of medical necessity. If they see a laboratory that continuously keeps submitting claims that don't meet medical necessity, they're going to start digging a little bit deeper. And we know for laboratories, CO50 is difficult because you're getting the orders from the physicians. You're putting a lot on them to make sure that they've got their medical necessity there. But ultimately, the laboratory are the ones that are billing. So when you're looking at your denials and like CO50. So if you are watching those denials and trending those denials, if you see it come in, you can start looking at it. You can go, is it a particular clinic? Is it a certain physician? Is it on certain tests? You know, what kind of things are triggering that lack of medical necessity? And then going back to your clinics and doing education with them so that they understand that medical necessity.
Cassie, as for medical necessity, especially on the back end denial, most likely it's bumping up to a policy. So as we indicated, you're billing with a CPT code or a diagnosis code that the payer may deem when they process the claim. They have policy in place that test and that diagnosis code doesn't meet their criteria for medical necessity. So are you encouraging labs, if they look at that CO50 and see if they've gotten those denials, to then look, like you said, at the test itself and then understand the implications from the payer of when they will reimburse for those tests?
Yeah, and ultimately then it's got to be education back to the ordering provider. And I know that's difficult for laboratories, but CO50 is a common one that you're going to see. And it's just being able to, close the circle and provide that education back to your providers if you're starting to see an uptick in the CO50. And, different types of testing that you might have, it's a little bit more, like definitive drug screens, ensuring that the diagnosis codes that are being used to trigger that definitive meets that medical necessity.
Right. And that's going to be based on the payers that you're submitting to and their individual policies.
Yeah.
We usually, if the payer doesn't have a policy, usually I look to Medicare as some guidance. But certainly you can dig in further with those payers to find out, why they're denying for medical necessity. And as, like you said, what type of feedback do you need to provide to your ordering? Because those tests may not be payable.
Yeah. And that's a lot of education back to the provider. So denials, even the front end processes, the data that's coming in, the demographics and the requisitions. If you see a deficiency in there, it's important to go back to your clinics and try to provide that education so that you're getting those clean orders in, and also trying to implement technology to try to prevent some of those bottlenecks that you might see as orders are coming in. And another big area that we see is duplicate billing. And so you just want to make sure that in your lists and your billing system, you have rules built to prevent this, because this will be a very big indicator for a payer that something's going on. So for example, if a physician orders, and this happens a lot, a physician will order a CMP and then a BUN and creatinine. The BUN and creatinine is a component within that CMP. And so if the claim goes out, the payer gets that and they see that duplicate billing, and then they're going to dig a little bit deeper. So you just want to go back and look at your rules that you've got built in your LIS, make sure it's covering all the components that are in a panel. And then even the billing system, it doesn't hurt to have rules built in both systems. So if for whatever reason it might get by in the LIS, if there's a rule built in the billing system, that prevents it from going out. It's kind of the final stop. The other thing that we do see, for example, like the health panel, which is a TSH, a CMP, and a CBC. Some payers want to see the health panel and not the individual codes, but not all payers recognize it. So it's important to, build rules in the billing system by payer so that those codes aren't going out to a payer that wants to see it as a health panel. So just reviewing those and making sure you have those in place is huge for that insurance that you're actually getting the right codes out.
I would say too, we're talking back end and denials, and I would say that those denial remark codes, for example, CO97 would be, this service is included in another procedure, or CO18, that's a duplicate. If you start to see those trends where particular codes are bundled or bumping up to another service procedure, those are your almost like a roadmap or a flag that says something isn't going right here in the payer system, and I need to use that and look for opportunities to, as we mentioned, fix the front end so that we can avoid those denials.
And another area is modifiers. The overuse of modifiers. The payers, if they put things in place or they use it to trigger audits, is, how are laboratories using 91 and 59, and are they using them correctly? And just make sure you're not maybe using both or reversing them. Just understand when and how you should use those modifiers.
Right. And I would say, 59 modifier, we keep saying this, but I'm going to keep saying it because I think it's important to understand. When you submit a claim, you're using these modifiers most likely to communicate to the payer that for 59, that the service is, you don't want it to bump up to as a duplicate, or you don't want it to bump up into the bundling edits. You're indicating to the payer that it is separate and distinct. There is no documentation that's submitted upon claim submission initially. So overuse of the 59 modifier, the 91, which is, I think, repeat lab test, that triggers, remember when we talked about algorithms and outliers, the more you use that, it puts you in an area of a payer is going to say, let's check and make sure that you're saying this is separate and distinct, or this is repeat, and you want us to override our edits. We're going to check in to make sure that that's factual.
Yeah, and in just all these areas, like Ann said, it is going to trigger the payers to look at you. So you just want to make sure that you've got good processes in place that can kind of prevent that scrutiny on you.
Or to be prepared with documentation and your policy and processes to support if there is an audit.
Yeah.
It doesn't mean you don't use these. And I want to make sure that we're clear. You want to bill appropriately and not bill to avoid an edit. However, these are the types of things that will trigger additional payer scrutiny. And so if you are utilizing these, and I really like the denial trends are important. It's important to manage that and look for opportunities to identify if there's areas where you're going to be an outlier or highlight to a payer that they want to come in and start sniffing around.
Okay. And then, so responding to the audit. So there's some things to keep in mind when you do get that request for an audit. You want to make sure that you have a primary point person at the facility that's going to be the one helping get everything collected. You want to make sure that you're providing comprehensive, accurate, and timely response. So that's where those requisitions orders come into play. Reviewing the documentation that you're going to send to the payer to ensure that it's going to meet the needs to show that, you have the information and that you did perform the services. And the other thing is the timely response. You want to make sure that if you need more time, that you ask for more time. You don't want to let that date go by. You want to make sure that you're communicating with the payer, and most of the time, if you ask for more time, they're going to give it. I haven't seen where they've denied it.
Mm-hmm.
So, ask. It doesn't hurt. And then as you're looking at stuff, if you need assistance or expert guidance, reach out, because these are important when you're getting these. And like Ann said, you don't want to get in a situation, then, you might have just an initial audit. Then if that audit does not go well, then you end up in a prepayment review. And then every claim that goes out is being reviewed with all the records. And it is a heavy lift on a laboratory when they get into a prepayment review.
Right. And having a point, usually with these audits, there is an individual that is assigned to the audit. So working with that individual, being in communication with that individual, I think is important. It helps recognize to the payer that you are performing your due diligence and that you're responsive. Um, I, I, I look at, I was once audited by the IRS, and so you get audited and it just puts you in panic mode because you know, you don't want to get in trouble. But keeping in mind that this is something that a payer is going to do. It doesn't mean you're going to get in trouble, but you need to be communicative with the payer on what is happening and give them visibility into your processes. And that's why we are recommending making sure you are aware of your processes. You're looking into these things, and you are prepared to answer those questions and be responsive to payers when they come knocking. And asking for assistance, before, you know, your deadline is passed is recommended as well. Don't be afraid to bring somebody in to help. We come in and help sometimes if it is a level that we can't assist and we believe that, you know, you're going to need an attorney, we'll recommend. But there are many times where we're trying to undig, we're trying to dig out, and it puts everything at a loss for the client because they're not getting paid, plus they're having this a big administrative burden to try to support the multiple requests. As Cassie said, you know, if the payer comes in and audits just 10 cases and you can't complete that audit, or what you've submitted isn't thorough, they're going to ask for more or put you on prepayment. So it really it is best practice to make sure that what you're submitting is as clean and as prompt and as accurate as possible the first time.
Yeah. And it's also doing a quick audit, and you can, you know, do a quick audit of 10 specimens, check your requisitions, check your, you know, your charges, just to make sure, walk you through the whole system to make sure that you're meeting the areas that you need to meet, just in case you get an audit. That way you'll feel more prepared when you do get an audit. You'll feel like you've got processes in place in those areas that may be troublesome.
And I would advise, the OIG has a compliance plan for labs, and part of that is mentioned doing self-auditing. So in preparation for an audit, you should do some self-auditing for yourself. Again, pull cases, have somebody review to determine, as Cassie mentioned, looking at your CPT codes, looking at your documentation, and making sure that if you are audited, you would pass an audit, or determine some of the questions the auditor may have so that you can fix those processes on the front end. I think it's important to a good compliance plan. You're very often looking at your billing and making sure that it's correct and compliant. So we want to make sure we do that. So I was trying to have an analogy. Some of this information I joke around like, you know, this is exciting to us. I think it's a really good topic to discuss, but, you know, I thought we'd come up with a fun little analogy, something different. But when we were putting together this presentation, I was going to say, don't put your head in the sand like an ostrich. However, when I was reviewing that, apparently that is incorrect. Ostriches do not put their head in the sand. They don't hide from a predator by putting their head in the sand. That is a myth. But what they do is they lie down and they look like a rock. So they look like the landscape, and they hope for the predator to pass them by. So I thought I could twist that analogy, even though I said don't put your head in the sand. I think that we can be an ostrich in that way as well, by not ignoring. We don't want to ignore the fact that audits are coming and you will be audited most likely. So we don't want to ignore that. We want to perceive the audit. We want to be aware if there is someone coming, and we want to prepare so that the auditors will pass us by, so that we will pass with flying colors, that if an auditor comes in and checks, they will say good job and move on their merry way, and you will not be eaten up. So that is the goal. So we want to be or not to be an ostrich. I think it was a good analogy, so I'm going to stick with it. But again, I think it's the discussion today. Really, we want to bring attention to be ready, folks. COVID, public health emergency is over. Waivers are over. Flexibilities are over. We have to get prepared to go back to really being on point with our billing compliance. As I stated in the very beginning, some of us became a little sloppy, and so we've got to fix that. And so let's be prepared. Let us, do your due diligence to make sure you're ready. So you can retain that revenue that you brought in, as well as protect additional revenue sources. Avoiding prepayment review is important. Alex, I saw some questions. I don't know if we want to go into
Yeah.
the Q&A.
Yeah, real quick, I just wanted to say thank you to you and Cassie both. That was very informative, and as always, we appreciate your insight. We're going to hop into Q&A here. Just wanted to quickly send out this offer in case anybody had questions or wanted to follow up with us for a free consultation, review of your revenue cycle processes. We're happy to meet with your team and provide an overview on that, or just any general RCM questions or questions about topics presented during today's webinar, feel free to open up that form, fill out some basic contact information, and someone from our team will get in touch with you soon. To hop into Q&A here, though, I think first question here was, when payers ask for medical records, does that include medical progress notes?
Cassie, you want to answer that?
And I should say to both you and Cassie, if there's anything that we'd rather not nail down today on the recorded call, might be a little easier to discuss offline, feel free to say that, and we can ask for follow-up via email.
I think when it comes to the medical records, you want to make sure what you're submitting supports the test being ordered. So if it may include the medical progress notes, it just depends on what's been documented and is it enough. So you want it as complete as you can get it. If the bare minimum of medical records doesn't meet that, then yeah, medical progress notes might need to be included in that.
Right. This is your opportunity to support the medical necessity. So the why the test was ordered. So it has to provide some background of the patient. And is this test going to help the ordering physician in that treatment of the patient? So that, like Cassie said, I 100% agree. It just depends on the medical record, if it supports that, if it has enough.
Great. Thank you both. For the next question, this one's a little more specific and in the weeds, but if you are only submitting a CPT code and diagnosis code, how would you submit progress notes upfront to avoid prepayment audit? For example, Humana's Medicare Advantage plan does this almost 100% of the time for molecular panels.
So it is most likely that is a prepayment review, and a payer, you're not, when you're submitting to a payer, you're not submitting progress notes. So they've if they have concern of what is being submitted, they will put you on what's called a prepayment review, and then you will have to submit your progress notes to that point every single time. As far as submitting progress notes with your original claim outside of a prepayment review, that doesn't happen electronically.
All right. And could we quickly repeat which tests were on the OIG work plan? I don't think we mentioned specific tests, but maybe areas of testing.
Urine drug screening, I believe the tox, so the definitive GO480 to GO483. It's the U005, so the add-on COVID test. And I just looked up in June 2023, they have on their work plan Medicare payment for clinical diagnostic lab tests. So that's a wide range of codes, but the point being made that if you're laboratory doing clinical diagnostic testing, OIG, again, they're most likely looking at specific outliers, MUE, specific codes. I just saw an OIG report about overpayment for 81408, which is tier 1 molecular or genetic code. So, if you were billing any genetic testing with that code, I would expect to see audits on that.
All right, thank you. Next question here. Some RAC auditors do not deem a correctly completed requisition as support for medical necessity for the test that was performed. What advice is there for labs regarding medical necessity documentation?
I would agree. I don't think the requisition is going to deem medical necessity. It just supports the order. So your medical you're ordering the medical record, the patient's medical record, talking about their history. That I think is more supportive of the medical necessity of the test.
I think this might go a little bit hand in hand, but next question here is that labs typically do not get progress notes up front from providers. How do you recommend labs obtain these?
They don't, and that's why it's really important to understand like Cassie mentioned, the front end, the workflow, and making sure you're utilizing technology to capture and be more efficient there. Because that's not what's typically submitted on a claim. This is usually what's needed in an audit. So you're having to go back to your ordering physicians to obtain. Cassie, are we seeing any success with laboratories implementing any processes that they're getting progress notes or medical records on every patient that they get from ordering?
No, and I think this is an area that laboratories really struggle with because, when they get those medical record requests, especially if you're in toxicology and do a lot of definitive testing, a lot of payers are requesting medical records. It's hard to get those from your ordering providers. And so just having that open communication with your providers, especially if you're providing, testing that will probably need some medical record support, making sure your providers understand that there are times that you're going to get requests for medical records so that when you're making those requests to your ordering physicians, they understand the why.
I think also looking at your utilization of the test that I'm going to pick on the GO483, the 22 plus drug classes, or even the 81408, which was that the genetic code, tier 1. It is a highly payable code. Payers, if they're paying for the large panel or a highly high paid molecular genetic test, that is going to flag you for an audit. It is. And so if you are overutilizing these more complex tests, be prepared that you're going to need supportive documentation.
Okay, I think we have a handful more questions here, but we were running a little long on time, so I want to wrap up with just three more here quickly. But let me see here. Okay, here's what I was looking for. So let's talk post-audit determination. If a payer or third-party auditor's verdict following an audit is not acceptable, unfavorable or unfounded, what advice do you have for next steps that can be pursued?
So you can do a second appeal dependent on the payer and dependent on the amount of take back. A lot of times I advise, we have a preferred vendor that we work with or we would refer you to help you with the audit. It just really depends if you have a good relationship with that auditor, you can submit a second appeal with more detail.
And then when we talk appeals, and do you and Cassie think that appealing a determination triggers a flag for future audits, or puts you on the radar, so to speak?
Appealing a determination from an initial audit, would it flag for more audits?
Or
Um,
or maybe just a lot of appeals in general. It's just appealing a determination is the question. And I think we probably have no way to know for
Well, and I
certain,
think
but
this also speaks to denial trends and denial management. So in looking for those opportunities to avoid those denials. So if you're consistently getting denied, for example, CO50 medical necessity, and you're appealing that with documentation, yes, I think that that does trigger you for more audits because you're billing for something that the payer is deeming not medically necessary. And instead of working to resolve and educate your providers and patients on, we can't run this test because this payer is not going to pay for it, or getting an ABN, um, it just because you're appealing it with documentation doesn't mean the payer is going to change their mind. They have a policy. So there's all these processes that are put in place to help appeal or to change a policy. But yeah, I would say that if you're consistently appealing some of these denials with documentation, if you're successfully overturning them, maybe it's time to go look to the payer for changing their policy. If you're appealing and continuing to get denied, you're going to continue, you're going to flag for audit for sure.
all right, let's close here on one of our favorite topics, Z code discussion. And I specifically, this is a pet issue for us, something that we've been diving in over the last few years on as the Moldex program is expanded. But now United Healthcare will be requiring Z codes for all Wave 1 tests on commercial lines of business effective August 1st, 2023. And Catherine's wondering about our thoughts in that. Maybe not so much the move by UHC, but what does this trend mean for the industry at large and the Z code requirements?
So Z code requirement, the Moldex program has been in place for a very long time. This isn't anything to do with COVID or infectious disease. It is a way for, I attribute, it's like a lab benefit management system. So this is a way for payers to pre-approve the tests that are being billed to a carrier. So we see that this is affecting labs primarily that are billing infectious disease. If you're billing for genetics, like this has been in place for a while, and so we figured out. Again, it's a prior auth, so it's the validating that the test that you're performing has passed the clinical utility and validity standards, and so uh, I think that the trend is as more technology, more types of tests that are developed, and starting, the payers are starting to see claims come through. It's a spike of utilization, which means because of that spike of utilization, and payers are paying a lot of money for, again, I'm going to go back to infectious disease. What they then do is pull back and they try to evaluate, and then they create policy. So that is what's happening. There's little policy surrounding infectious disease, and so we're starting to see the development of that policy, and they're wanting that Z code. They got rid of their United Healthcare got rid of their lab benefit management program, and so they're just rolling it all under the Medicare, the Z code. So it's just helping them manage the testing, and really it comes down to the medical necessity of the test. And
Thanks.
I think we'll see continued development of policy, continued lab benefit management for molecular and genetics for that prior authorization, review of documentation before, limitations on the tests and the diagnosis codes that they're willing to pay for.
Thanks, Ann. Safe to say it's a trend that's not going to be pulled back anytime soon.
No, nope.
Okay. Well, we're going to go ahead and wrap up here. I know we did have a few questions we didn't get to touch on. I'm going to go ahead and pop out that offer screen one more time. Please, if you'd like to follow up on something we didn't get a chance to address today, fill out that form and we'll get in touch with you. But otherwise, I'd just like to say thank you again to Ann and Cassie for sharing their time today. Great expertise, and we really appreciate it.
Thank you.
Thank
All
you.
right. Bye, everyone.